On behalf of Intas Pharmaceutical Limited. Okay. Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited, I Dr. Mithilesh Nayak welcome you all to this 5th edition of Practice Pulse in Hypertension. So today we are going to discuss important aspect in the management of hypertension, that is with regard to masked hypertension and newer approach in the management of resistant hypertension. And to moderate this session, we are having with us Dr. J.C. Mohan sir. He is the chairman and head Department of Cardiology at Jaipur Golden Hospital, New Delhi. He has a rich experience in managing the various cardiologist patients, and he has published more than 250 research papers in various index journals. And he is currently the president of Apex Society for the CM in Cardiology and the recipient of various awards: Sujay B. Roy Gold Medal for the Cardiology Society of India, Shirley Award for the Best Research Paper by the Cardiology Society of India. So without wasting much time, I hand over the digital podium to Dr. J.C. Mohan sir. Over to you, sir.
Thank you, Dr. Mithilesh. Good evening, ladies and gentlemen. Welcome to this one of these series of these webinars called Practice Pulse in Management of Hypertension. And I believe this is the 6th in series. And hopefully those of you who have been with us right from the beginning must have found this series useful and practical. We of course know that we can't discuss enough about hypertension. Hypertension continues to be a major public health problem all over the world, including India, and data from the 4th National Health Survey published last year in Public Library of Science from India suggests that we have about 225 million individuals with hypertension with an older definition of 140 by 90, and that is 22% of the entire adult population, and the number would jump to nearly 52% of the adult population in case you take the newer definition proposed by ACC-AHA. That puts a great burden. In 50% of our adult population has hypertension. That puts a great burden on society, healthcare providers, insurers, government, doctors, and also on patients with regard to having a vascular disease, because hypertension is a vascular disease. So as I said, we need to actually understand more and more about hypertension. And in this series, we will be talking about masked hypertension, another interesting area, and that will be discussed by Professor Tiny Nair. Dr. Tiny Nair is a great friend of mine. He's head Department of Cardiology, PRS Hospital, Trivandrum, Kerala, and he's the recipient of Best Doctor Award by Government of Kerala in 2006, and one of the most inspiring doctors of India from the Economic Time 2019. And he has been on the editorial board of most of the journals published from India and several from abroad, including European Journal of Heart Failure and Hypertension Journal. He has authored 4 books and he has published more than 40 papers, and he is above all a great thinker, a great philosopher, great academician, and somebody who actually understands the epidemiology of cardiovascular disease far better than many of us. This talk on masked hypertension would be followed by a discourse on resistant hypertension by Dr. Devdas Shafakar, who is director and consultant nephrologist at Supreme Kidney Care, Nasik. He is the professor of medicine, Dr. V.N. Pawar Medical College, Nasik, and the president of Nasik Kidney Foundation and Nephrology Forum of Nasik, and past president of Indian Society of Nephrology West Zone, editor-in-chief of Journal of Maharashtra Association of Physicians, and he has been awarded with several accolades. Following that, we would have some discussion on another case scenario by Dr. Omkar, and And of course, Dr. Omkar is a professor in head department nephrology and renal transplantation with more than 25 years of teaching experience in the field of nephrology. And he's an examiner for DM and DNB nephrology, published a lot of papers, and is the past president of Indian Society of Nephrology East Zone, past vice president of Indian Society of Nephrology, and member scientific committee of Indian Society of Nephrology. We'll also be joined by our panelist and presenter, Dr. Narsima Pai, who's an associate professor of cardiology and consultant intervention cardiologist at Kasturba Medical College, Bangalore, published multiple research papers, has been awarded with Dr. TMA Pai Gold Medal for the best outgoing student in MBBS, and has won the API's Best Scientific Paper Award in 2000 and the CSI Best Scientific Paper Award from CSI Bangalore branch in 2001. I think with those introductions, we get on with Dr. Tiny Nair's presentation. And I'm sure that we are going to have it more informal, more interactive, and you are going to enjoy this entire 1.5-hour session on the nuances of hypertension as our experts see those. Thank you very much. And Professor Nair, please.
Thank you, Dr. J.C. Mohan, for those kind words of introduction. Give me a moment by the time I share my screen. Is my screen visible and am I audible?
Yes, you are audible and the screen is visible.
Thank you. Thank you all. So the topic today is something very interesting and very close to my heart, and that is masked hypertension, the story so far. We are all aware about the term white coat hypertension. White coat hypertension is the moment a person sees a medical worker checking his blood pressure, there is stress and the blood pressure shoots up. This is called white coat hypertension. If we do an ambulatory 24-hour blood pressure measurement of a white coat hypertension, what we see is this. The top black line is systole, the bottom black line is diastole. You can see that as the patient is in the hospital, the blood pressure is extremely high, up to about 180 millimeters by 110 diastolic. As it goes home, 2 hours later, the blood pressure is in the normal gray band, normal. And at the end of the day, again, when he comes to the hospital, it goes up. The typical white coat hypertension. This is a typical textbook white coat hypertension. But first thing, understand that what we see in India is not textbook. It is something entirely different. Because Indian scenarios are different. This is the photograph of the OPD of our hospital, waiting room outside my room, outside the cardiology waiting area. You can see people are waiting with papers and anxious, crowded. They don't know when their numbers will be called. They're angry, they're hungry, they're upset. Do you think this is a good time to check their blood pressure? Obviously no. Obviously no. Even before that, the ordeal starts hours before. When they reach the hospital, stand in a long queue to get those papers, the chips, which will enable them to get a registration, right? So obviously, white coat hypertension in India is different. That is point number one. That is all we are talking about, the kind of hospital that we, all of us work. Okay, think about rural India. Think about rural India. You can see the doctor sitting there on a table, surrounded by patients, right? And if you can see that picture, that lady with the white hair there, right? She is suffering from isolated systolic hypertension of the elderly. Isolated systolic hypertension of the elderly, right? You can see this lady, yellow marked. That lady is suffering from diabetes and hypertension, multiple comorbidities. You can see this gentleman in the back. He has resistant hypertension. You're going to listen to a talk on resistant hypertension a little later. And you can see that gentleman right there trying to push his piece of paper to the doctor. He has white coat hypertension. So the Indian challenge is even more. How is this doctor going to find out who has what, and how is he going to stratify each patient and give him a proper treatment? And that is the whole reason why years back the concept came out that we need to record office, out of office blood pressure. Blood pressure is not something that you record in office and treat, right? Out of office blood pressure is the best. But there are even more challenges in India. Obviously, the first thing that came in was the ambulatory blood pressure, right? So we put the ambulatory blood pressure, send him home. For the last 10 years, we have enough experience in ambulatory blood pressure, its interpretation in various niche areas, various subsets, and we have understood a lot. And probably in the last 5 years, we have also understood that there is another way, and that is called a home blood pressure, whereby the patient carries this usual looking BP apparatus at home with some subtle differences. He puts it on a particular time, morning, afternoon, night, and records it himself. The records are mostly 3 times automated, inflate, deflate, 30 seconds gap, inflate, deflate, 30 seconds gap in the third recording. And what is shown in the screen is an average value, and that goes into the instrument memory. At the end of 1 week, when the patient brings it back to us, we connect it to a PC and get the average home BP. The algorithm is standard and set. So home BP and ambulatory BP has given us an ability to oversee something that is a 24-hour affair, not just that 5-minute interaction with the patient in a place like hospital where the patient is anxious and not really very comfortable. Now, once we saw in great detail the ambulatory blood pressure, a couple of simple things which we are aware we should understand. Now, that is an ambulatory blood pressure record, right? 24-hour record. And if you see, I have labeled that night period, 9 o'clock to 6 o'clock, night period, right? And that is the day period. So you have the day and the night. And generally, as a rule, the day period is governed by the sympathetic nervous system. The daytime, we are all under the activities of sympathetic system. Okay, dominant system is sympathetic. We are talking, we're angry, we are all stressed up, right? And at night, the system is mainly governed by renin-angiotensin and volume. That is the basic, simple system. And we know that during daytime, the blood pressure is higher. And at night, when the person goes to sleep, the blood pressure slowly drops down, what we call as the standard nocturnal dip. And not just that, early morning, after that nocturnal dip, early morning, the blood pressure goes up. And today we know that morning surge has so much to tell us the development of stroke and myocardial infarction. That's a topic different. But the point is, from that morning BP till that night dip, there's a progressive lowering of blood pressure. And that is what we always refer to as nocturnal dip. We know there are hyper dippers, there are non-dippers, there are reverse dippers and all kinds of stuff. But the point is, at night, the blood pressure comes down to a lower level and settles down. So if you see an ambulatory blood pressure, right, we have day BP, night BP, early morning BP, 24-hour BP. Now, which of them are most important? So this is important in understanding masked hypertension. For example, in this graph, the x-axis is systolic blood pressure, 90, 100, 200, 210, systolic blood pressure. The y-axis is a 5-year cardiovascular risk of death, an event, right? So we are talking about a death, a hard endpoint. Now, if you see, the lowest black line is the clinic blood pressure, the office blood pressure. Now, in that office blood pressure, let's say somebody has a 120 blood pressure, I marked that red line, and that is his risk, right? Maybe 0.8%, 5-year risk. And now you have a person who has a blood pressure of very high, 170 systolic, severe hypertension in the clinic. And if you take his risk in this graph, this is called the Dublin outcome study, you see that the risk goes up by what? From 0.8 to about 1.2%, right? But in contrast, now if you take the nighttime BP on top and extrapolate the same, you see that at 170, you have got a risk which is about 3 times, right? So that is important. So the nighttime blood pressure is the most important predictor of cardiovascular events. That is something that we need to keep in mind. So in an ambulatory blood pressure, the nighttime blood pressure is the most important predictor of event rate. So if you don't understand anything, you are given an ambulatory blood pressure record, just look at the nighttime average, or it is called a passive average. And that will give you the best measure to talk about the patient outcome. The nighttime average is taken as an upper limit of 120 by 70. Anything above is abnormal. Now, if you look at the diastolic pressure in the x-axis from 850 to same thing. Look at that. The nighttime curve is far more steeper, giving a better predictability of the cardiac event rate. Okay, so that is important to understand, point number 1. Now let us deviate to something else. So this is one of our hypertensive patients who came in with this ECG. Now anybody who doesn't even understand how to interpret an ECG can make out that yes, the V1 S wave but plus V5R is large. What we call as the Sokolow-Lyon criteria is left ventricular hypertrophy. V1S plus V5R more than 35 millimeters. We also know that if we take the AVLR and the V3S, what we call as the Cornell criteria of more than 20 millimeters is there. So there is no doubt there is left ventricular hypertrophy by the EKG. Now this patient of hypertension with a left ventricular hypertrophy, it is important to understand that isn't bad prognostic factor. For example, if you do an echo, see the ECG predictor of left ventricular hypertrophy, the sensitivity is very low. Echo also, for example, this patient shows significant left ventricular hypertrophy. So the heart has left ventricular hypertrophy. The important is, if you go back years back in 1992 and look at the Framingham study data and look at the ECG LVH, which is not a very sensitive method, but still, if your ECG showed a left ventricular hypertrophy in an hypertensive patient, understand there is chance of getting a coronary heart disease is 3 times higher, stroke is 6 times higher, and cardiac failure is 15 times higher, right? So a simple ECG, right, a cheapest tool of left ventricular hypertrophy in our hand in a patient of hypertension tells us that this patient has significantly elevated risk. Many often we see in the ward that we see, left ventricular hypertrophy, hypertension, right? When people see a troponin positive or people see a pro-BNP, they run, right? But here, understand that this is a very powerful tool to tell us that there is something grossly wrong. Now, problem comes in when you find that your patient has left ventricular hypertrophy for ECG by echo, but his blood pressure is normal or near normal. So what is happening? My office blood pressure, clinic blood pressure is normal or maybe just pre-hypertensive, slightly elevated, and I see a significant left ventricular hypertrophy. Why does this happen? And that happens in a situation called masked hypertension. So the clinic blood pressure is normal or near normal, but there is features of significant target organ damage. That is how we suspect masked hypertension. How does masked hypertension look like? This is one of the book pictures of masked hypertension. Look at that. That arrow shows the daytime blood pressure. That light green, systolic blood pressure, light orange, diastolic blood pressure. Look at that. The blood pressure is slightly elevated during daytime. Slightly elevated during daytime, that arrow. But at night time, it is severely elevated. That bottom green bar is sleep. At night when he sleeps, blood pressure is significantly elevated. Remember that we had said, at night when we sleep, blood pressure should drop. Here instead, it is very high. So this is the typical masked nocturnal hypertension. Now we have data to say that this nocturnal hypertension is far more often associated with left ventricular hypertrophy and target organ damage. And this goes unrecognized. Because when we see the patient in our office or clinic, mild hypertension, we don't give much importance to it. But he has significant left ventricular hypertrophy, significant retinal damage, significant target organ damage because of an elevated blood pressure at night, which we would miss out unless we do an ambulatory blood pressure or maybe a home blood pressure. Why this happens is because of bursts of sympathetic drive at night. Normally, night when we sleep, the blood pressure should have come down because the sympathetic drive goes away. But somehow, in masked hypertension, there are bursts of sympathetic drive. Why this occurs is very complex. We're not going to that. But there are very interesting data. For example, this is the neurogenic abnormalities in masked hypertension that came in circulation a couple of years back. Very interesting data set from Italy that showed that if you look at the muscle sympathetic nerve activity, which we call as MSNA, and look at normotensives there, you see the nerve activity is low. You see in masked hypertension, it is significantly elevated. So at a time when the masked hypertension patient's blood pressure goes up, the muscle sympathetic nerve activity increases. Okay, and that is what drives up, and that is why it is responsible for so much of target organ damage and cardiac event rate. So this discordance needs to be understood by the physician. What discordance are we talking about? The discordance between your recorded blood pressure in the clinic versus the target organ damage. For example, if I see that my patient's blood pressure is very high, but there's no target organ damage. Kidneys are fine, his retina is good, ophthalmoscopy is good, he has no ventricular hypertrophy, he never had a CVA or a TIA. See, what is happening? High blood pressure, no target organ damage. White coat hypertension, discordance. Or just the opposite, blood pressure normal or near normal and severe target organ damage, masked hypertension or nocturnal hypertension. Right, that is the discordance we are talking about. So the moment you see discordance, many people ask us, in India, should we do ABPM for everybody? No, ambulatory blood pressure is costly in India. You can't do it for everyone. So if you're selecting somebody, the one you should select is a discordance between your recorded BP and the target organ damage. Now, masked hypertension is very important. Many people don't understand that. For example, if you take this large data set where you see that normotensives or pre-hypertensives, they are cardiovascular events, is close to that straight line. But the moment that normotension in clinic or pre-hypertension in clinic is associated with a nocturnal masked hypertension, see that the boxes are far away, 2.08. So more than double the risk of cardiovascular events. Same thing for stroke, same data set. Look at the stroke events. Again, if you look at the masked hypertension coupled with normotension or pre-hypertension, the risk about 2.9, about 3 times the risk of stroke. So higher risk of stroke, higher risk of cardiovascular events with masked hypertension. So we should not miss masked hypertension. A couple of years back, we wrote an interesting essay on this, common but underrated, common but underrated, are we neglecting these hypertensive subsets in India? And this is what we found. This was something that fascinated us. Okay, for example, this is one of our patients. Look at that. Night, I have marked the night. Daytime, the blood pressure is actually on the lower side, right? Excepting for little white coat effect, the blood pressure was slightly high when he left the hospital. But look at that. The entire evening and night, the blood pressure is high. Entire evening and night blood pressure is high, not just night. Okay, so the entire period of time, the blood pressure out of office is high. There's another kind where you see that the blood pressure is elevated only at night. Only at night. And if you see the new European Society guideline, they have in detail talked about night, the masked hypertension being divided into day and night. And that is, of course, you can see the early morning rise shown by the red arrow. Now, we did a large study. In fact, 16 of us joined together. We did that study on ambulatory blood pressure, the India ABPM study. And in fact, this is one of the largest ABPM trials in the world. In fact, this came in Journal of Human Hypertension last year. 27,000 patients, 27,472 patients. And the sum and summary is that white coat hypertension was in 12%, masked hypertension 19.3%. So understand that 20% of the patients that we see can have masked hypertension that we might be missing out. Right. So it's important that we recognize masked hypertension, treat, otherwise target organ damage will happen and progress. This is the other study that we did where it's called the India Heart Study. Again, large data set, self blood pressure measurement. The specialty was rather than doing ambulatory blood pressure, we did a home blood pressure monitoring. We gave the patients instrument which they took home and measured blood pressure at home for a week. And again, 18,918 patients. White coat 24%, masked hypertension 18%. So masked hypertension is there roughly about 20% of patients in India. And that is very, very troubling. Right. Now, masked hypertension now is divided into masked day and masked night. Is there a difference? Yeah, if you look at the masked daytime hypertension, so some people will have predominantly daytime out of office hypertension. They tend to have more of work stress, right? Their blood pressure may be normal at the hospital, but they have a lot of work stress. They can have, today, domestic stress during lockdown has shown us that, very interestingly, the ambulatory BP pattern during lockdown is different, whereby people have daytime masked hypertension when they're at home. When actually at home, they should have relaxed. There should not have been blood pressure. Smoking is very closely related to daytime hypertension. Obviously, people don't smoke at night. And they tend to have, this group tend to have poor effort tolerance. So work stress, domestic stress, smoking, and poor effort tolerance has been connected with masked daytime hypertension. In contrast, the masked nighttime hypertension is the one that is far more common and easy to miss out, is connected to obstructive sleep apnea. So if somebody says that he has an OSA, features of OSA, maybe thick neck, he's obese, he becomes drowsy at daytime or at meetings, slips off at traffic lights. Think of OSA. Sleep deprived youth. This is important. Today's youth are in IT and they're connected to the US and work at US timings, right? So they are sleep deprived. So the sleep deprived youth who is working in the IT, and of course, the large number of young boys and girls they sit to and surf at night and they are sleep deprived. They tend to have masked nocturnal hypertension. Diabetes, CKD, and cardiometabolic syndrome are three diseases which are closely linked with increased episodes of masked nocturnal hypertension. So we should keep in mind OSA, sleep deprived youth, diabetes, CKD, and cardiometabolic syndrome. We also got interested in something else, and that was masked hypertension and dementia. Masked hypertension and dementia. For example, if we, this is one of our old recordings of ambulatory blood pressure. You can see the color, it is almost fading out. Daytime BP normal, and night there was significantly elevated blood pressure. And many of these patients came with very early dementia. I mean, don't misunderstand, they're not the kind of dementia you expect to come in like Alzheimer's in a wheelchair. No. They come and say, the wife says that my husband tends to now forget where he put his mobile, where he put the keys. He tends to forget anniversary dates, birthdays, and all that. He was so sharp. And the husband would say, no, doctor, now I am busy, so I could not remember, otherwise I am fine. You put them on a mini-mental scale, and you would find that there is MCI, or minimal cognitive impairment. MCI, minimal cognitive impairment. And that is early dementia. And many of these early dementia might show normal and near normal blood pressure in the office. You do normally we find that if there is some kind of dementia, you do a CT scan, you find lacunar infarcts, right? But if you take this kind of patients, which we were seeing, take a CT scan, it'd be absolutely normal. But there's no lacunar infarct. But if you do an MR, a cerebral MR, you tend to find what is called as leukoariosis or white matter hyperintensities. This white matter hyperintensities are a telltale sign that there is hypertension. But where is the hypertension? His office blood pressure is normal, masked hypertension. So a subset of masked hypertension might show just as a minimal cognitive impairment, and you might miss it out. And unless you treat them, they would progress on to significant dementia. So are they connected? Dementia and minimal cognitive impairment, mild or no clinic hypertension, and ABPM showing masked hypertension? Yeah, we do believe that they are. In fact, last year we published a Journal of Human Hypertension. We wrote an essay and a comment that challenges of hypertension and dementia in India, and how this problem is gradually increasing in India. And what is interesting is that this data, this old data, showed that there is something very unusual. If you take patients of dementia, that the age in the x-axis 70, 80, 85, and the blood pressure on the y-axis. Now, if you draw a line at 70, you see if you take the red line, which is vascular dementia, as the patient develops gross dementia, the systolic blood pressure tends to drop over time as they grow older. Same for non-vascular dementia, Alzheimer's. So as the patient becomes more and more demented, the blood pressure tends to drop. Why does it drop? We don't know. It is suspected that maybe their sympathetic activity comes down, renin-angiotensin activity comes down, they become thinner, maybe they eat less food, less salt, so many theories. But as they become more dementia, their blood pressure tends to come down, drop down. It is documented. And in fact, a very new data set which came in December last year very clearly shows the association of midlife to late life blood pressure patterns with dementia, which means hypertension followed by hypotension, midlife hypertension followed by late life hypotension. In fact, if you take all those dementia patients and look into their blood pressure pattern over a period of 5 years, you see that blue line where you have hypertension in midlife followed by hypotension in late life are connected with dementia. Okay, right. And not just that, a lot of new papers today are talking about hypertension and cognitive dysfunction, and how hypertension and cognitive dysfunction can be related to masked hypertension. This is the GMASH-COG trial, which has shown that there is a distinct relationship between masked hypertension with cognitive decline over time. So unless we detect masked hypertension properly, it might progress onto far more problem of ongoing dementia. The dementia risk, the role of blood pressure patterns is being now recognized. Now, the final thing is something very, very interesting before we end. That is conversion of sustained hypertension. Understand that. Conversion of sustained hypertension. Your patient has hypertension, right? Clinic BP is high. You treat him and you convert him to masked hypertension by suboptimal therapy. And this is very common in India. We give patients small dose. Patients say, doctor, don't give me very strong medicine. Give me light. Or you are giving 10 milligrams, you will need 5 milligrams. So what happens is his clinic blood pressure comes down, but his night blood pressure does not get affected. And this is now being recognized. It's very interesting. For example, the first idea came when they tried to compare low-dose chlorthalidone. This came in JACC last year. The chlorthalidone, 2016 JACC, low-dose chlorthalidone versus hydrochlorothiazide. And look at the data. The blue is hydrochlorothiazide. Focus only on hydrochlorothiazide. So hydrochlorothiazide lowers the office BP almost as good as chlorthalidone, up to about 14 millimeters of systolic blood pressure fall. But the nighttime blood pressure is falling only by 4 millimeters. Okay, so your patient who had daytime and nighttime hypertension with hydrochlorothiazide is converted. Somebody was only nocturnal hypertension. Okay, right. So if you look at the data, very interestingly, so this patient is treated. Look at the red line, that is hydrochlorothiazide. So this patient is treated, his daytime hypertension has come down below that line. So it is normal blood pressure. But if you focus, say, night 2 a.m. and look at his night blood pressure, it is gradually going up. So he still has hypertension, but it is masked. He has this hypertension at night, he's partially treated, you are happy, he's happy. Whenever he takes his clinic blood pressure, it's normal. But at night, his blood pressure is still high. So what happens to these so-called masked hypertensives whom we have created by taking care of their daytime blood pressure? Surprisingly, they do worse than those who have native masked hypertension. And that is very interesting. In fact, year before last, 2017, masked hypertension, understanding its complexities, was a very interesting article that came from California. Stanley Franklin wrote this essay and the details, whereby he highlighted the data set from what is called an IDACO data set. It's a large data set that very clearly showed that in red line, that red line is the treated masked hypertension. So when hypertensive was treated and converted to masked hypertension by suboptimal treatment, and his outcome, as you can see, cardiovascular events are far more than the so-called native masked hypertension whom you have failed to treat. So the group of hypertensives whom we convert to a masked hypertension by suboptimal treatment, whereby his office BP has become normal, we are happy, but his night blood pressure continues to remain high, has a far worse outcome than the de novo so-called masked hypertensive who is going undetected. And this is very important to understand. So at the end, ladies and gentlemen, the story so far in masked hypertension is fascinating. Point number one, 20%, roughly 20% of Indian patients have masked hypertension. Point number two, there are specific subset characters which we are learning now. We didn't know. Masked daytime hypertensive, masked nighttime hypertensive, masked day and night hypertensive. Their characters are different. Their outcomes are different. Their target organ damages are different. Are their treatments different? We don't know the answer to that question. More target organ damage compared to a person who has got hypertension, masked hypertension, more chance of left ventricular hypertrophy, more chance of dementia, simply because we are not treating that problem at all. He still has that burden despite looking good in the clinic. Suboptimal treatment converts a hypertensive to an masked hypertensive. This is a new information, and I think it's very troubling. So suboptimal treatment can create a host new problem, including masked hypertensives. And always remember, do an ambulatory blood pressure when there's a discordance between target organ damage and your patient's blood pressure. Patient's blood pressure is very high, no target organ damage. He might be white coat hypertensive, doesn't need any treatment. In contrast, you might have somebody who has got near normal blood pressure, 140 over 92, but his left ventricular hypertrophy by ECG or an echo or target organ damage or microalbuminuria. You should be careful that am I missing masked nocturnal hypertension. The story continues, and it is really, really fascinating pertaining to masked hypertension. Thank you for your time and attention. I'll give back the floor to Professor J.C. Bond, sir.
Thank you, Professor Nair. I think that was an excellent overview of masked hypertension. you did emphasize that mass hypertension is a distinct phenotype. Number 2 point, you did make out that within this phenotype, there are subtypes: nocturnal, diurnal, sustained, untreated mass hypertension, and native hypertension. So there are probably 4 or 5 subtypes, subphenotypes. That is an important aspect. The third aspect is that whenever you see target organ damage in a person who has office blood pressure normal, think of mass hypertension. That's a powerful message. If somebody has an echo left ventricular hypertrophy, retinopathy, microalbuminuria, and the office blood pressure normal, think of mass hypertension, unearth it by using ABPM and or home blood pressure monitoring. That is the third very important message. The fourth important message you gave was the minimally cognitive impairment and mass hypertension. I think that is a very, very important thing to keep in mind. And above all, the fifth point, which I understood, you said, if you use short-acting drugs, and especially in suboptimal doses, then you are going to create a monster of mass hypertension, much more than it is prevalent as of now. If the prevalence now is 18 to 19%, and you use short-acting, especially short-acting suboptimal doses, because even short-acting drugs in adequate doses might provide 20 hours blood pressure. We have seen with losartan, but suboptimal and short-acting is the worst cocktail that is going to promote mass hypertension, and probably we may be doing great disservice to society. So those 5 messages I think I have summarized, and we will have good number of questions and answers on that. I can see number of questions in the chat box, but before we'll take all questions together, include everybody together, including panelists, and I asked Dr. Shafakar to talk about the resistant hypertension, the new approach, and we are going to take all the questions. We are not going to leave any question unanswered, but we'll take help of everybody. Why only talk about mass hypertension? Hypertension has big spectrum, and we are going to talk about everything. Dr. Shafakar, please.
Yeah, thank you, Dr. Mohan. And after having listened to Dr. Nair regarding mass hypertension, a very interesting talk, and I enjoyed the talk. Let us talk about resistant hypertension. Now, resistant hypertension per se is a phenomenon which is getting important in our practice because there are so many patients who are becoming very difficult to control. Now, just to put the things in perspective, what are the best proven non-pharmacologic interventions for prevention or treatment of hypertension? All these are known to you, but just to tell you, what is the extent of fall in blood pressure? That is very important. For example, aerobic exercises, dynamic resistance, isometric resistance, DASH dietary pattern, all these are known to you, dietary potassium, etc., etc. But the fall in blood pressure is to the extent of, say, 5 to 2 to 4 millimeters of mercury systolic and diastolic. So the non-pharmacologic measures which are well known to us, if we put them into practice, you will definitely get some benefit. However, when we talk of resistant hypertension, before we define what is resistant hypertension, there is something called as pseudo-resistance. It is simply because of a poor blood pressure technique. So we know what is the correct technique of measurement of blood pressure, and that should be employed before we say that this is resistant hypertension. Just a comment on resistant hypertension in CKD. We know that in patients with CKD, the blood pressure is very difficult to control, and the incidence of resistant hypertension in patients with CKD goes on from 40 to 70%. And there are many reasons why this occurs, but it is only sufficient to say that if you have a patient with CKD, you're going to use more than 3 or 4 drugs as far as control of blood pressure is concerned. So if you want to define what is resistant hypertension, uncontrolled blood pressure despite the use of optimal doses of more than 3 antihypertensive medications, of which one should be a diuretic. This is a standard definition of resistant hypertension. And we know what are the targets of blood pressure. And for those people who do not achieve the targets by using more than 3.5 to 4 drugs, that is defined as resistant hypertension. The prevalence is around 30%. I already mentioned that it is higher in patients with CKD, maybe in patients with diabetes also. Now, if you look at the treatment of hypertension, 30% of people are untreated, 35% are treated but uncontrolled, and 35% would be treated and controlled. So therefore, in spite of having so many antihypertensive medications for our use, we are still not able to control the blood pressure in so many individuals. There are many causes why this occurs, and this is just a bar diagram to show you that there are so many causes. For example, secondary hypertension, non-adherence, etc., etc. I'll go to that later on. Now, just to show you some terminology of resistant hypertension, there's something called as drug-resistant hypertension, where the office blood pressure is more than 140/90, in spite of using more than 3 to 4 drugs. Then you have what is called as control-resistant hypertension, where the blood pressure is, the target is achieved, but the number of drugs required is more than 4. Then you have what is called as refractory hypertension, where the target is not achieved in spite of more than 5 drugs. Then you have what is called as apparent treatment-resistant hypertension, where the assessment made in a cohort study with drug dosages was unknown, but here the number of drugs is required is more than 3, and the blood pressure is still more than 140/90. You may have what is called as severe drug-resistant hypertension. The blood pressure is more than 160 systolic. It's a separate class of patients. And then you have pseudo-resistant hypertension, which I have already mentioned. Now, just to put things into perspective, there are some new things which are happening in the definition of resistant hypertension. So what is the updated definition of resistant hypertension? The failure to reach goal BP less than 130/80. But remember that despite adhering to full doses of an appropriate 3-drug antihypertensive regimen, which includes an appropriate diuretic for kidney function, a CCB, and a RAS blocker, which is maximally dosed. So here, the point which was made by Dr. Nair in the last talk regarding the dosages of drugs. If you are not fully dosed as far as the choice of drug is concerned, then you are not going to label it as resistant hypertension. You must have a full dosage, maximum allowed dosage of all these drugs. In addition, all the following need to be present before diagnosing someone as having true resistant hypertension. So adherence with low sodium diet and medications is very important. Good sleep quality, substitution of drugs with greater effect within the same class, and rule out all secondary causes. So look at the third point, which is very, very important. So this is a new addition to the definition of resistant hypertension. Substitution of drugs with greater effect within the same class. That means if a person is on a diuretic, and if you substitute that particular diuretics with another diuretic, which is maximally dosed, and you get a better result. For example, you substitute hydrochlorothiazide with chlorthalidone, and you get a better result. Again, that cannot be termed as resistant hypertension. Or if the person is on, say, telmisartan, and then you switch over to some other ARB, maximally dosed, and you get a better result, then again, the person cannot be having true resistant hypertension. So you have tried everything, including the proper dosages. You have tried to change the drug within the same class, and in spite of that, if the blood pressure is not controlled, then this is true resistant hypertension. There is a very good correlation between sleep, insomnia, and hypertension. And here it is mentioned that insomnia combined with a short sleep duration, which is typically less than 5 hours, is associated with a significantly increased risk of hypertension. There was a study called Nurses Health Study, 71,000 nurses 45 to 65 years of age, 10-year follow-up, and here they wanted to study what is the relationship between sleep duration and the incidence of hypertension. If the duration was less than 5 hours, the relative risk of developing resistant hypertension was very high as compared to the other durations of sleep like 6 or 8 hours. Now, this is a very important slide. What are the issues associated with treatment resistance, and what are the management considerations? So you can have treatment resistance because of volume control, and if the volume is not controlled, then probably you will have treatment resistance. So you can switch over from a thiazide to chlorthalidone to a loop diuretic. If the heart rate control is inadequate, then again it can lead to resistance. If the renin or aldosterone levels are low, then you can treat that by a low salt diet, avoid nighttime shift work, and addition of amiloride. If the renin is low and the aldosterone is high or normal, then you can use an MRA. If you can use a split dosing of medications, and if that improves control, that will also take care of resistant hypertension. Medication adherence questionable, then of course you can diagnose that by various methods, which I'll tell you later. Now, the pattern of BP response to medications outside the clinician visit times is unknown. For example, you can talk to the patient regarding the meal effects on blood pressure, duration of the medication effect, and the side effects of the medications. Again, if you take care of that, you probably will control the blood pressure much better. And something related to sleep and obstructive sleep apnea, again, that also can be taken care of. So there are a lot of issues which are related to treatment resistance and which can be managed, and then the resistance can be overcome. The two most common non-disease causes for apparent resistant hypertension are white coat and poor medication adherence. Now, poor adherence is a very, very important problem, and that appears in almost 40% of patients. Now, there are some trials of doing urinary metabolites assessing adherence in hypertension. So there was one very good study which was published from UK, and here they showed what they did was they tried to assess the urinary metabolites of antihypertensive drugs and try to diagnose poor adherence, because the patient always used to say that I am adherent as far as the control of, as far as the ingestion of antihypertensives was concerned. And they found that almost 45% of patients were proven to have non-adherence. Similarly, you can do therapeutic drug monitoring as far as control of blood pressure is concerned. And there are some studies from the US where you can do the TDM assays of drugs for hypertension and prove non-adherence. White coat effect I will not talk about at all. There are some drug-related causes of apparent resistant hypertension, like non-narcotic analgesics and NSAIDs, sympathomimetic agents like simple decongestants, some stimulants like methamphetamine, alcohol, oral contraceptives, cyclosporine, erythropoietin. All these are drugs which will contribute to resistant hypertension. Once you have diagnosed resistant hypertension, this is a stepwise approach. Evaluate common causes of pseudo-resistance. The drug choice is very important. Then, of course, you must do ambulatory blood pressure monitoring and prove that this is a true resistant hypertension. And you must distinguish between true resistant hypertension and a white coat. Of course, then you should rule out all secondary causes of hypertension before you label it as true resistant hypertension, and look at the adherence also. And when you come to therapy, remember that the first three drugs are well known to all of us. They are ACE inhibitors, ARBs, calcium channel blockers, and a diuretic. So whenever you are choosing a diuretic, you may choose chlorothalidone over hydrochlorothiazide because of the longer action as far as the chlorothalidone is concerned. And if you have a CKD, then the loop diuretic is preferred because the other diuretics will not act because of the low GFR. So as far as diuretics are concerned, you can use the long-acting thiazide diuretics, and you can, this is just a chart to show you the different diuretics which are available and where do they act as far as the kidney is concerned in the nephron. So you have carbonic anhydrase inhibitors, you have loop diuretics, potassium-sparing diuretics and the MRAs, and you have the thiazide and thiazide-like diuretics. So commonly we are using thiazide type diuretics in clinical use. So the thiazide diuretics are hydrochlorothiazide, chlorothiazide and bendroflumethiazide, and then you have thiazide type diuretics like chlorthalidone, metolazone and indapamide. So in patients with CKD, I already mentioned that you must use loop diuretic. There are some very good studies where amiloride has been used because amiloride antagonizes the epithelial sodium channel in the distal collecting duct of the kidney, and that is functioning as an indirect aldosterone antagonist. So there are good studies to show that substitution of hydrochlorothiazide with amiloride might also be useful. Once you have used up all the three drugs, including a diuretic, then you have to go to the fourth drug. The fourth drug is usually an MRA, which can be either spironolactone or eplerenone. And there are good studies to show with spironolactone. Important study is called an aspirin study, where they have showed that if you use spironolactone as an MRA in resistant hypertension, you will get a good control of blood pressure. The other drugs which can be added on are beta blockers, direct vasodilators. Sometimes instead of spironolactone, you can use eplerenone also to treat resistant hypertension because there are some side effects related to spironolactone. Amiloride can also be used as an indirect aldosterone antagonist. If the blood pressure is still not controlled, of course, we have other drugs like alpha blockers, beta blockers in specific indications, and then you have the centrally acting drugs like methyl dopa and clonidine, and the direct vasodilators like hydralazine or minoxidil. This is all we have as far as the hypertensive therapeutic armamentarium is concerned. And whenever you are choosing these drugs, you have to choose them judiciously. Sometimes in renal patients, it is very difficult to control. So there are some trials to show that transdermal clonidine at weekly intervals can be used. We are using minoxidil to a great extent. We know about the side effects of spironolactone in dialysis patients or in CKD patients where there is a risk of hyperkalemia, and that really needs to be monitored. I will not go into the details of which are the good combinations and which are the bad combinations because that is not the topic of the day. Suffice it to say that you should use your drugs judiciously and the combination should be correct and it should be properly dosed. So if you have resistant hypertension on ambulatory blood pressure, differentiate between true and the white coat resistant hypertension, and then on ABPM, you can have controlled resistant hypertension, you can have a masked resistant hypertension, you can have a true resistant hypertension or a white coat. And depending on what is your classification, you can decide what kind of therapy is there. This is a flow chart, how to approach a case of resistant hypertension. I will not go read through it again, but suffice it to say that once you have given the initial drugs, then you can go stepwise fashion and then go on to select your drugs properly. Now, having talked about the drug therapy, the other things in resistant hypertension is use of various devices. Now, what is the rationale for device-based therapy in hypertension? Now, we know that the sympathetic nervous system is very, very important as far as pathophysiology of hypertension is concerned, and the level of blood pressure can be dictated by the sympathetic nervous system. So therefore, there have been a lot of physiological data to show that if you control the sympathetic outflow from the brain or from the periphery, the renal sympathetic activation and its role of pathophysiology in hypertension has been alluded to in various trials. And if you block the sympathetic outflow at whatever sites you want, then you are going to get control of blood pressure. So there are trials like renal sympathetic denervation, and the rationale is obviously to control the sympathetic outflow. I will not go into the details of the procedure of renal denervation, but suffice it to say there are few studies which were published initially. Simplicity Hypertension 1 with very good encouraging results. Again, the second trial was Simplicity Hypertension 2. Again, it showed that the fall in blood pressure was significant at the end of 1 month to the extent of 20 systolic and 7 diastolic. But the third trial of Simplicity of resistant hypertension with denervation was a failure for various reasons. So therefore, the denervation procedure went out of vogue for some time. But remember that the procedure is coming back now. And why did the Simplicity Hypertension 3 trial fail? Probably because the patient selection was improper, operator failure because it highly dependent on the person who is doing the procedure, and what was the procedure, how it was done, and what paraphernalia was used, what catheters were used, etc., etc. This was discussed, and then the denervation technique probably will come back after some time because there are many trials which are now coming up. This is one trial called a spiral hypertension trial where it showed that denervation was useful for both control of systolic and diastolic blood pressure. Just to enumerate, these are all the trials which have been shown what are the effects of renal denervation. And here I have just tried to enumerate all the trials about the renal denervation as a method of controlling blood pressure. There are other devices also which can be used. These are the European Society of Hypertension guidelines as far as how to use renal denervation. They have given a stepwise approach. Remember that the important thing is that it should be performed in a place where it is a center of excellence for control of blood pressure, because the person should be very, very well trained. The other therapeutic targets can be a baroreflex, which is a therapeutic target. So there's something called as baroreceptor activation therapy, where modulation of baroreceptors has been shown to cause a decrease in the sympathetic nervous system activity, and there's a fall in systemic vascular resistance as well as fall in heart rate. And this occurs via a neural mechanism. So there's something called as a Rios badge system, which is an implantable device to treat hypertension. And some human trials have gone on. A 3 months badge device placed patients showed an office blood pressure reduction of almost 21 systolic and 12 diastolic. And the generations of the Rios systems have changed. There is something called as Mobius HD device. Again, it increases the baroreflex response. It reshapes the blood vessel, and I'll show you. This is the device called as vascular dynamics, and this device is placed in the carotid vessels. It reshapes the vessels and it modifies the baroreceptor signaling with every pulsatile wave, and that is how it controls the blood pressure. Now, with BAT application, there's a sustained reduction in blood pressure. There are some trials which have been published. One trial called as Rio Pivotal Trial in 265 patients, again showed good results, and the long-term data is also very, very good. I'm going a bit fast because of lack of time. There's something called as median nerve modulation. It is a technique where an E-coin is implanted under the forearm skin to activate the median nerve. And it is a low-powered electrical stimulus. It basically is related to multiple pathways in the brain which are stimulated to control the blood pressure. So at the end of 6 months, they found that the median nerve modulation was also probably an effective procedure. A very interesting therapy is developing called as central arteriovenous coupler therapy for resistant hypertension. So the technique is that you create a small arteriovenous fistula between the iliac artery and vein with a controlled shunt flow, and this creates a low resistance vascular bed for the systemic vascular resistance. The systemic vascular resistance falls and the systemic hypertension also reduces. This is a novel technique. There are, of course, some problems related to that, but again, there are some human trials which have occurred. Again, it showed that the fall in systolic and diastolic blood pressure was significant, but there were problems like leg edema and venous stenosis. But it's an interesting concept to reduce the peripheral vascular resistance by creating a fistula. Deep brain stimulation is, of course, theoretical. Vagal nerve stimulation is also theoretical. Right now, it is not really useful. So I have tried to tell you how to approach cases of resistant hypertension. How do you define what is the new definition, what is new as far as definition of resistant hypertension is concerned. So resistant hypertension is a complex clinical problem with multiple pathophysiological mechanisms, and it can cause a significant target organ damage, more common in patients with CKD and diabetes. And if the management of resistant hypertension is unsatisfactory, you are going to get a lot of target organ damage. If you are not able to control the blood pressure with whatever drugs you have, then you can think of using various devices, which I have tried to mention. But of course, they have to be done in centers of excellence where people are very well trained. So to summarize, updated hypertension guidelines continue to emphasize combination therapy and adherence with drugs and lifestyle. Think of MRA as a fourth drug in addition to diuretics, CCPs and RAS blockers. Emphasize on good sleep quality and duration of sleep, which should be more than 5 hours. And the device-based therapies can also be useful in the future. I will stop here. If there is time, then I will present my case. Over to Dr. J.C. Mohan.
Thank you, Dr. Shafikar. I think you took us through the entire gamut of resistant hypertension, defining resistant hypertension by new definition of 2018. And of course, the phenotypes of resistant hypertension, which is controlled resistant hypertension, true resistant hypertension, apparent resistant hypertension, and of course, you did mention about refractory hypertension. So obviously, we have, of course, some data which is accumulating from India, which suggests that maybe about 10% of the entire population has a true resistant hypertension. And that would give a number close to about 25 million people with resistant hypertension. And if refractory hypertension is taken at 1 to 2%, then we are talking of 2 to 5 million people with refractory hypertension. Obviously, that large number of people, no devices are going to be used. No devices are going to be the way to go forward. No pacemaker, stimulators, carotid stimulation. Ultimately, it would have to be better drugs, drug compliance, long-acting drugs, rational combination of drugs, starting with the proper number of drugs. And of course, as you rightly said, adherence would be an important, and avoid drug-drug interactions which might be raising blood pressure. The devices are always attractive, and to people like us who are intervention cardiologists, they seem to be as if these will give us a new lease of life. Now that the coronary angioplasties are coming down, we want to do these things, but I'm also aware of the facts. This is not going to happen in my lifetime. I mean, these things probably will occur. We recently, of course, saw the publication of Anthem trial, which is a baroreceptor stimulation. In India also participated, and Kamal Sharma is one of the authors of that paper. So we are happy, actually, those things are happening. The issue of renal denervation, somehow, I have looked at this whole issue very, very carefully. I know there are a lot of trials and a lot of people are doing. My actually personal thinking about renal denervation is something akin to what Jim Ferguson actually described some 25 years back. Now, Jim Ferguson was an intervention cardiologist. He is sadly no more, in fact. And he once said that, no, those are not his original words, but with regard to something. And he said, winners never quit, quitters never win, but those who never win or never quit are the idiots. The renal denervation actually tells me that story. And I think people will keep doing that thing. I have got a lot of renal denervations done actually from a student of mine who actually came from US and went back. I don't know. I'm not too sure it works. Anyhow, things are good. I think we did learn a lot of lessons, but your important things, which let me summarize, is that 1/3 of the cases have what you call apparent, what is called pseudo resistance, and you should take at least 1/3. That's what you said. And what we should be doing is, of course, appropriate drug therapy and of course, see that there is a compliance, there is adherence, and that we, instead of using short-acting drugs, use long-acting drugs, and we use rational combination. That is number one point which I understood from your talk. Number two thing which you said was there is a sequence in which the drug should be used, and as you said, A, C, and D are the drugs which have to be given to everybody, and then followed by fourth line spironolactone, and then of course fifth line you did talk of beta blockers, central sympatholytic agents, and direct vasodilators. My third point, which I understood from your talk, was that the fact remains that a good number of these people actually have CKD, and there, of course, you may have to use loop diuretics, and that too twice a day instead of the thiazide-like diuretic, especially the EGFR less than 30. Even when the EGFR is little over 30, these drugs start losing efficacy, and hence you may have to change other drugs. I did understand the other point that the mineralocorticoid receptor antagonism, including eplerenone, have a role to play, and we, of course, will have some more data. We had some data with finerenone, which of course is a synthetic mineralocorticoid receptor antagonist and does not raise potassium level, and is a drug actually which recently in Fidelio DKD study has been shown to be renoprotective and cardioprotective. We do believe that in hypertensive individuals, it might have some role to play in some subset of resistant hypertension. Those are, and of course, you talked about devices, which I'm happy, and I think devices are not going to be the mainstay of the treatment, but in some truly refractory patients, they would be useful. And you did emphasize one fact that subclinical hypervolemia probably accounts for a large majority of resistant hypertension. And there is the role of diuretics. You may not see edema, there may be no puffiness, nothing. There may be a little bit of hyponatremia, dilutional hyponatremia, but still occult hypervolemia is probably the single most important cause of true resistant hypertension. That is all I learned from this talk. So those are some of the summary of your talk. And now we would go back to our attendees who have multiple questions to ask. Amit, you have anything to say before we go on to the questions?
No, sir. You can go ahead, sir.
Okay.
You can continue. Yeah.
So we will go to the questions raised by our attendees, and let me go back to the first question. So the first question is, please enlighten management of intractable hypertension with no secondary cause and triple drug combination already being given. The question is where prazosin or clonidine combination is also not bringing it to complete normalcy. That means the individual is talking about refractory hypertension, 5 drugs already on and the blood pressure not controlled.
So I think, so can I answer that?
Yeah, please go ahead.
Yeah. So we have already mentioned in my stepwise approach that if you're maximally dosed as far as CCB and ARBs are concerned, along with a diuretic, which should preferably be called chlorthalidone if there is no renal failure, then you have a choice of adding a direct vasodilator, which you have already given, and a centrally acting drug. But remember that when you are adding all these drugs, you have to look at the side effect profile, because many of these drugs could add to postural drop of blood pressure, and you have to look at the intravascular volume also. If you have a combination of almost 5 to 6 drugs, and in spite of that the blood pressure is not getting controlled, then you have to look at all the things which I mentioned, where look at the volume, look at the adherence, look at the salt sensitivity, and look at all the other treatable factors which we tend to ignore, and then try to control the blood pressure. And if in spite of that it is true resistant hypertension, then of course you can think of devices.
I think that is a very, very valid, very cogent answer to this whole complex issue. Most of these people actually have some degree of CKD. Most of these are elderly women, if I remember these patients correctly. When Dr. Gupta has pointed out these 5 drugs and still not controlled, I am reminded of patients who have like this, and barring few gentlemen, they all have been women, by the way. So it's interesting actually. So the question to Professor Nair, let us first take your question and then of course your comment on that. The question is mask hypertension a different type of hypertension or a phenomenon of blood pressure variability?
I believe that it is a different type of hypertension, but also we can get a masked hypertension, as you have seen, by converting by inappropriate treatment from a sustained hypertension. So there are 2 pathways perhaps. There's some people who their genotype, their phenotype is where they have just a masked hypertension. And I think these are people who have got a more tendency for LVH, more tendency for dementia. And that is by itself a different subset. Like we talk about isolated systolic hypertension of the young, isolated hypertension, systolic hypertension of the elderly, or that kind of stuff. We today believe that this is a distinct subset. But today we also know that we can also get another hypertension is sustained and get converted from that onto masked hypertension also. And one small thing about that previous question that was asked, that many often we see that in resistant hypertension, the patients are on spironolactone, but they are on very suboptimal dose. It might be 25 milligrams OD or 25 BID. Understand that spironolactone for hypertension needs to go to very high dosage. In fact, In Europe, if you see most of the case reports of resistant hypertension, they need up to about 600 milligrams of spironolactone. So before we declare that it is not, MRA is not effective, I think we need to check that whether the patient has enough dosage of MRA.
So, Dr. Nair, that is very interesting observation you have made, because just 10 days back, we had a webinar in which I chaired a session where Dr. Neil Poulter and Mike Weber were the speakers. And Neil said, if 25 milligrams spironolactone doesn't work, no other dose will work. He was very categoric. Based upon Escort BPLA study, he was very categoric. If there is no response with 25 milligram, there wouldn't be any response with 100 milligram.
We were talking to Dr. Brian Williams in one of the meetings, where he very clearly showed in his slide that one of the reasons why MRA doesn't work is suboptimal dosage. And he said the top of the line dosage for spironolactone is 600 milligrams. So in fact, we all said that, do you really say 600? He said, yes. If you really want to control your resistant hypertension, you might need to go to as high as 600 milligrams, because that is the level whereby your serum aldosterone would probably get cut. So I really don't know. What is your take on that? Would you really believe that if 50 milligrams doesn't control?
I don't go beyond 50 milligrams. That's the first thing. We'll ask Dr. Shefekar. But I'll tell you an interesting story. I had this doctor friend of mine. He's a surgeon. He's now 78. But when I was 60 years, he had a resistant kind of hypertension. And, as usual, doctors are badly treated. And so he was on 4 or 5 drugs and he wasn't responding. And one resident doctor, he said, can we have a look at the potassium? His potassium was on a lower side, and he was given 12.5 milligrams spironolactone, and lo and behold, his blood pressure became normal, and all drugs could be withdrawn, barring giving spironolactone 12.5 milligram a day. I'll ask Dr. Shefekar to comment on it, then we go to the next question.
Yeah, so I'll do that. We have 2 other panelists, Dr. Mohan. So you want to ask for their comments?
So after you, I'm going to Dr. Narasimha and then to Dr. Om Kumar. We have enough time.
Yes. Okay. So as far as the dose of spironolactone is concerned, I think that the doses which we are using in CKD or non-CKD. Now in CKD patients, we have to be very careful. So we usually do not exceed more than 25 milligrams. As far as non-CKD patients are concerned, the maximum doses which we have used is about 100 milligrams of spironolactone, not more than that. And here again, we find that if the response is the best response which we have got is to 50 milligrams, and very rarely we have had to exceed that dose. And then beyond that, I think it's a useless increase in the dose.
I think exactly this is what Dr. Neil Poulter was saying. Dr. Narasimha, what is your take on this?
I fully concur with what Dr. Shefekar has told. Am I audible?
Yes, sir. You are audible.
Yeah, I think 50 to 100 is going to be the upper limit. I have never crossed 100 milligrams. And we must also take into account that you are going to treat this patient with other antihypertensives. And definitely one of them would be an ACE or ARB. So the risk of running into hyperkalemia, even in a non-CKD patient, goes up. So if it works at 50 milligrams. If it does not work, there's no point in increasing it beyond 100 milligrams.
Dr. Om Kumar, your viewpoint? Yes, sir.
I also agree with the same explanation and the philosophy of treating hypertension in these difficult patients. We all have to check the adherence and compliance of the drugs, maximally tolerated doses of the drugs. And at the same time, we have to check that patient may not be taking some drugs which are causing the hypertension difficult to control. Like Dr. Shefekar will agree with me that many transplant patients who are on immunosuppressive treatment and some transplant patient or some CKD patients who are taking anti-tubercular drugs and who are on rifampicin. The patients taking rifampicin, you give any amount of antihypertensive. If you do not discontinue rifampicin, it will be very difficult to control hypertension in those subset of patients. So these are the very important small points in managing difficult refractory hypertension. So most of the time we are able to, in very few patients, we have to use device-based therapy for resistant or refractory hypertension.
So the next question is, I'll ask Dr. Pai to respond to that, and then others can take turn. The question is, if somebody has a nocturnal dip, normal or exaggerated, should we avoid nighttime dosing in these individuals?
Not essentially. I think it's better to space the drugs, one, or better to split the dosage of the drug, and if required, probably repeat your ambulatory blood pressure to see exactly what is happening after a trial of 4 to 6 weeks.
Dr. Om Kumar, your viewpoint on this?
Yes, chronotherapy is very important in managing hypertension, and even for the patients who are having nocturnal hypertension or nocturnal masked hypertension, you don't need to stop the evening dose. Best time to give antihypertensive is at bedtime.
So I also have to tell you that 3 days back, I was chairing a session with a hypertensionologist from Cleveland. This guy's name is Dr. Luke Joseph Laffin. And he runs a hypertension clinic in Cleveland. And he said, I don't believe in chronotherapy. I'm just trying to tell you his views. And he says, I think Hygia study, which Raymond Hermida published, and chronotherapy was established as a drug which causes 45% greater reduction in cardiovascular and cerebrovascular endpoints when you shift one dose to the evening, probably is too good to be true. And his argument was, first thing, in 7 years, there is no dropout. There is 100% follow-up. That looks a little difficult to believe. And number two, he said, well, people have to still show reproducibility. Other studies have to come up. And what small studies are there, probably they are not fitting in that whole thing. But we will not today discuss chronotherapy because otherwise we'll be in a loop from which we'll not be able to come out. But I'll ask Tiny to make a comment whether somebody who's a profound nocturnal dipper, let's say shows more than 20% decrease, is it safe to give a drug at bedtime?
Yeah, it's safe. First of all, the exact thing that you said, that the Hygia chrono trial has been under intense debate. And only a couple of days back, we were discussing that the European Heart Journal has asked the authors to come out with the original data. And the authors have not done that yet because they all said that it's too good to be true. You shift one dose at night and you get kind of almost 50% reduction of cardiovascular events, 45% stroke, and all that is too good to be true. So they said that you give us the data. The data has not come for us to comment. But let's not go into the controversy. But all the drugs we use today are long-acting, not just long-acting, they have a good TP ratio. And because they have a good TP ratio, they're unlikely to cause a severe blood pressure drop a couple of hours later after they take it. So whatever time they take it, it is not going to cause an immediate drop or further blood pressure drop right at the moment, unless you give some very strong fusimide diuresis and all that, which we are not going to give, obviously. All the standard antihypertensives that we use today are safe, despite hyper dipper. If the blood pressure is high, see, we should see a hyper dipper with a normotensive, why should we give him blood pressure drug at all? So if he is a hyper dipper or an excessive dipper with elevated blood pressure during daytime, I think we can still give it at bedtime, the drugs that we use, and it is safe.
But we also have to keep in mind that we can use our common sense. More often than not, non-dippers or reverse dippers have CKD or diabetes or have an OSA. If these are the situations, then positively, if you are using a short-acting antihypertensive, again, probably giving in the bedtime makes a sense. There are a lot of people who are still fond of Ramipril as an antihypertensive drug, the short-acting drug. Losartan, which is again a short-acting drug, which we can give. So in situations where you want to give this kind of drugs, and of course, regular kind of metoprolol, the metoprolol tartrate, I have seen a lot of people, you and me may not be using, but there's a large number of people who use it. and it's a short-acting drug. Maybe if you want to use it, that would be this thing. I think we understand what we are discussing. The next question is from Dr. Khosla. It says, no, I think before that we have to take a question, Dr. Ashok Agarwal. What is the clinical importance of isolated diastolic hypertension, sometimes seen in the young people? So we'll start with the tiny U and then Dr. Shafekar, and then we rotate down.
Unmute, sir.
Yeah. Traditionally, we used to all say that in the elderly, we used to get an isolated systolic hypertension and a combined systolic hypertension in the younger age groups. An purely isolated diastolic hypertension is not very common. In fact, there was a time when we all believed that probably the large amount of organ damage and the problems of hypertension are driven by systolic hypertension. I still believe that. It's true that the systolic number carries with it most of the burden, most of the problems of hypertension. Whether an additional diastolic elevation adds up to something, we really don't know. So if I have a young man who has a systolic blood pressure which is normal, a little elevated diastolic blood pressure, I would still wait before I put him on an antihypertensive medication. Try to reassess and make sure that really he needs a drug, not just looking at his diastolic blood pressure, but looking at his target organ damage, looking at his comorbidities, and looking at his total global risk factor. That would be my approach.
Any comment?
Yeah.
Any comment on that?
Yeah, can I say something?
Yeah, please, doctor.
So we have some patients who are younger and the blood pressure is like, say, 120 by 100. I think that is this is the question which has been alluded to. What about patients who have a blood pressure of 120 by 100 or 96 or something like that? So in that, I would agree with Dr. Nair that I would do ambulatory blood pressure monitor, look at the record, look at the target organ damage, and then try and give therapy. We also should remember that the systolic head is very, very important as far as organ perfusion is concerned. So once you start antihypertensive therapy, and if the systolic head is going to drop, then you might do disservice to the patient and there could be some detrimental effects. So before starting antihypertensive therapy, you have to look at these two things, ABPM as well as target organ damage, and then decide about whether you want to treat or no.
Yeah, I think but you know, in young people below the age of 40 years, the isolated diastolic hypertension probably accounts for 10% of all hypertension. That is based upon this epidemiology study called GENOA. And the GENOA study showed that about 10% have isolated diastolic hypertension. We don't know much about the epidemiology of diastolic hypertension. How do these patients behave over a period of time? Should we be treating them? Do they get benefit out of treatment? This question has been asked to me several times, and then I have to try to look into the literature. Unfortunately, literature is silent on that. And again, it tells us that when something is uncommon and would not interest the companies, nobody is going to put money in it, and no data would come out of it. Maybe the National Heart, Lung and Blood Institute can take over and do this thing. Now the question, Dr. Om Kumar, to you. I want to ask you this particular question. This is by Dr. S. Khosla. What is the most effective, which is the most effective ARB in resistant hypertension?
I think telmisartan works in treating resistant hypertensions.
No, he's not asking actually, he's asking most effective. So there are two things, most safe, most effective, or maybe most prescribed. So, but here the question is most effective.
Probably you can say most efficacious. That is probably what he wants to know.
If you are talking efficacious, I think telmisartan wins over. There is no question about that. But effectivity wise, we have data, as you were saying, from William White, actually from that big ABPM study showing azilsartan scores over even olmesartan and valsartan. That was data published in January 2016, Journal of Hypertension, 3,000 odd patient multicentric ABPM study showing that there is statistically significant 2 millimeter difference between this and olmesartan, azilsartan and olmesartan. And olmesartan had 2 millimeter compared to valsartan. And the valsartan and ramipril were equal. So efficacy is a different, efficacious, yes. Tiny, your comment actually, this is an interesting question.
Yeah, I know. See, when olmesartan came in, their main selling point was this is the strongest of all the sartans, right? Double-digit BP reduction. And when azilsartan came in, the study, as you mentioned, very clearly showed that it is 2 more millimeters more potent. So I think they are all talking about potency, meaning that how many millimeters of blood pressure drop occur with a milligram equivalence of dosage of a drug. But I think people should understand and take it home that it is not just the blood pressure drop. Let us say we have a drug A that causes 10 millimeter BP drop, a drug B that causes 5 millimeter BP drop. But the drug B might have a better TP ratio, right? So at the end of the 24 hours, the drug B might have a TP ratio of 85%. The drug A, which was causing 10 millimeter drop, might have a TP ratio of maybe 40%. So which one will we choose? We will choose a drug with a better TP ratio, right? So I think the point of efficacy, meaning that one dose, how much of millimeter of blood pressure maximal fall it causes, has very little effect on. We should take the, like you said, telmisartan is very efficacious. Everybody accepts that. Now, overall, if we take 10 patients or 100 patients on telmisartan versus azilsartan, despite being potent, are we doing any good to them because of this 2 millimeter blood pressure reduction? We really don't have that data.
I think that I think I'll ask Dr. Narasimha in that Dr. Pai, in this whole context, when we talk of olmesartan, azilsartan, where do you fit? I mean, your thinking. We also are aware that with olmesartan, we have a randomized study, reasonable size roadmap with Hermann Heller conducted from Germany. We are aware of Oscar and Orient from Japan, but the difficulty with Japanese studies are we people can't digest, like we can't digest sushi, we can't digest Oscar and Orient. But I think roadmap was a pretty good study of 4,000 odd patients by Hermann Heller. And I would ask Dr. Narasimha Pai your comment on that.
I think only time is going to answer your question. Whenever a new drug is launched, there is obviously more enthusiasm and the company is behind propelling that new molecule. So I think time is going to tell. As of now, probably I would still go ahead with telmisartan being a more efficacious and a pretty well tolerated drug. So we have to see both the 24-hour BP control, the TP ratio, as well as the patient tolerating with minimal side effect. I would still go with telmisartan, which I think is quite time tested now, compared to probably azilsartan or your olmesartan.
Very reasonable comment. Dr. Shafakar, sir.
I have a different point to make. What I want to say is that we are going to enter in the future in the era of personalized medicine. So the sensitivity of each individual to a ARB is going to be different, and that we'll be able to detect in the future. So as I mentioned in one of my slides, you are allowed to switch the ARB from one to another and then dose it maximally and to see whether he is going to respond. So for example, you might switch from telmisartan to azilsartan and you might find a better response, or vice versa, because that individual is responding to that ARB in a different way. So in the future, probably we'll be having different subsets of patients who would respond variously and differently to various ARBs. And once you know that, you will be able to select your drug properly.
I agree
and
with
in
Dr.
roadmap trial, actually cardiac events were more.
That is because there was a rapid fall in blood pressure. Rapid and more people had 110 millimeter in these elderly people. I do agree with Dr. Shafakar, but the point about individualized or personalized medicine and precision medicine, I am hearing these words for 40 years, Tiny, and I probably am at the end of my life. So I am not too sure this bloody personalized medicine, when will this mature? But let us keep the hopes alive. Next question, and this is Dr. Nair for you. This is for Dr. Siraj, and he's asking what method is more reliable to detect mask hypertension, ABPM or home blood pressure monitoring?
Masked hypertension, today we have data that very clearly ABPM scores over home blood pressure monitor. Home blood pressure monitor has so many advantages. It doesn't disturb your sleep. It is less expensive. It is very easily obtainable. But then when we are talking about the typical masked hypertension of nocturnal masked hypertension, there is a study, there is again a Chinese study that has shown that it is 25% more accurate in picking up cases of masked hypertension. So ABPM scores in detecting nocturnal masked hypertension.
Absolutely right. I think ABPM scores over, but you know, I read actually, I was actually participating in one of these India Heart Study program 2 months back. So right 2 months back, there is a group of individuals who published a paper on mass hypertension in, I think it's May 2020. The journal is called Heart and Lung Circulation. Now, we haven't read about that, but it's very good actually. And the first author is an Indian. His name is Hiresh Thakkar. I don't know the gentleman, but he did a beautiful analysis. There are 11 studies so far comparing ABPM versus home blood pressure to detect mask hypertension. 11 studies. And he did a meta-analysis of all those 11 studies. And he showed, and you rightly said that ABPM picks up anything from 40 to 70% more mass hypertension, 40 to 70%. But average of 11 is that home blood pressure, the pickup rate is 50%. Average of 11 studies, home blood pressure pickup rate, mass hypertension 50%, when gold standard is ABPM.
Yes.
Okay, we go to the next question. Now, this is a situation. Actually, this is a situation of a patient, and Dr. Patwari wants to discuss. Let us quickly go to 70 years old patient on amlodipine and atenolol for last 20 years. Blood pressure 170 by 100 and no other comorbidity. After changing to Telmi plus amlodipine twice daily regime, still blood pressure is around 150 by 95. How to investigate further? Can we add chlorthalidone, then further investigate if BP is not controlled? This is for you, Dr. Shefakar. He says, initially patient was on amlodipine, atenolol. He changed to telmisartan plus amlodipine. He hasn't mentioned what dose. As you rightly said, what is the dose? That is important. But he says it is 150 by 95. Should he add CTD, chlorthalidone, or go to the maximum dose of these two drugs?
My answer would be that if it's an elderly individual, 70 years old, the drug of choice is a calcium channel blocker along with a diuretic. So that is the combination which you should opt for. That should be maximally dosed. So therefore, if you are using a CCB with a diuretic like chlorthalidone, then that would be the best combination instead of adding an ARB right from the word go. If you have used up this combination of a CCB and a diuretic, which is maximally dosed, and if you are still not able to control the blood pressure, then you are very well okay as far as the addition of ARB is concerned. But because this is an elderly individual, you might choose to add an alpha blocker for the reasons which are obvious. But I would say that CCB along with a diuretic plus or minus alpha blocker on an ARB is a good choice.
Good. Dr. Pai, let me throw a dart to you. And the question is actually in this thing, whether you use chlorthalidone or indapamide, if you were the treating doctor.
If
now
there are
that
no other
Dr. Shefakar has said that he would use a thiazide diuretic, I'm asking you a point blank question. Would your choice be chlorthalidone or indapamide?
chlorthalidone.
Okay, good. And that, but you know, the weight of evidence is in favor of both almost equal. You talk about the SHEP trial, Mr. Fit trial, SHEPX trial, on this side, and of course L heart, and here you have IVAT, you have actually advanced study also where indapamide has been used, and of course we have progress, and we have many other things. I think the balance is almost similar kind of thing. If I was to answer, I will say I will find it tough actually. The only thing is, I have seen more hyponatremia with the chlorthalidone. I don't know, maybe it is more longer acting, but it's my personal viewpoint. I'd ask Dr. Om Kumar to comment on this and we move further.
I think the ideal choice in this elderly patient will be combination of calcium channel blocker and diuretic. And as you have rightly said that it is difficult to choose between chlorthalidone and indapamide.
Okay, so
I think in some patient, in this age group of patient, we can think of even adding beta blocker also. Beta blocker, if we investigate this patient for evidence of any atheromatous coronary artery disease, so we can add with beta-1 selective beta blockers also.
Yeah, but I think, beta blockers are going out of disrepute. Even in atherosclerosis, we are no longer giving beta blocker unless a vascular event like MI has occurred in recent past. That too in recent past. Remember, the Sripal Bangalore's review, which Tiny would remember, and he beautifully said that if it is 2 years past MI, beta blockers, no, they are not going. But anyhow, we come to this important question. It actually is for Dr. Shafekar, but we are going to ask everybody your view on clonidine in elderly hypertensive patients with the resistant hypertension. Clonidine.
Yes. So if it is a resistant hypertension and if it's an elderly individual, then remember that clonidine has got some side effects, which all of us should remember. One of the important side effects is, of course, postural drop of blood pressure, which is very important as far as elderly people are concerned, because they've got very stiff vessels. And in that situation, the person can become symptomatic as far as the postural hypotension is concerned. The second important side effect which I have seen is excessive thirst in these patients. And the third important side effect with clonidine is drowsiness. So if you are using clonidine in elderly people, the monitoring for all these side effects needs to be done. And if you find that the postural hypotension is more than 20 millimeters of mercury, you have to be very, very careful. Or you look at the intravascular volume of the patient and then try to control the postural drop of blood pressure.
Good. I think we agree with all the points Dr. Shafekar has made. So Dr. Pai, suppose instead of clonidine, the question is I will use moxinidine. What would be your reaction to that? Because some of these side effects don't occur with moxinidine. So, Dr. Pai, your comment.
But if you look at the efficacy between moxinidine and clonidine, I would place clonidine above moxinidine.
Absolutely.
One. Second is where do you like to position? It is clonidine or other central acting drugs are always going to be position number 4 or position number 5 once you have exhausted the maximum dosage of your first 3 drugs.
Number 5. Okay, we go to the next question for Dr. Tiny Nair. Which drugs are better choice for treating mask hypertension? And do we have any data with regard to cardiovascular protection for drugs managing mask hypertension?
No, see, as you manage hypertension, masked hypertension management should be similar. The challenge lies in detection. And once you've detected it, see, for example, if you see the new IHSS guideline, they're basically like, A plus C, low dose, then you put A plus C, then you go to 3 drug A, C, D. In fact, they don't even put diuretic in the 2 drug thing like ESC, right? So they kind of calcium blocker is all pervading all through 1, 2, 3, 4, everywhere, whatever pill combination you give. So I think the idea should be we should give long-acting drugs and we should start on combination as has been very clearly shown. Now, see, most of the masked hypertension that you and me, we are going to pick up are patients who already have a target organ damage. See, I'm absolutely healthy. I come for a checkup. I have nothing else. Target organ is normal. BP is normal. Will you put me on an ABPM? No. Right. So we are suspecting an masked only when we have an ABPM, doing an ABPM when there is a target organ damage and office BP normal. So already you have somebody with a target organ damage. So obviously I will start on at least 2 drug combination, keeping in mind that I might have to go to a 3 drug combination. Now that 2 drug combination obviously would be a RAS inhibitor with a CCB, maybe at bedtime, not thinking about chronohygia, but then generally at bedtime, so that we have a challenge of nocturnal hypertension in hand. And logically, if we give it at bedtime, probably it might act at least logically better. So the treatment combination would be a 2 drug combo to start with the CCB and then RAS inhibitor to start off. If not getting control, add a third agent, which would be a diuretic.
Yeah, I think that's a very right comment. You know, your talk actually forced me to think what we were doing 40 years back. So me and Dr. Upinder Kaul wrote a paper in the International Journal of Cardiology, effect on labetalol and regression of left ventricular hypertrophy. And the paper was published in 82. So that is a 38 years old story. But when I was reviewing the literature, we found that 10% of the adult population has echo evidence of left ventricular hypertrophy. And that data, epidemiologic data, came from Italy. Paolo Verdicchia and I think another gentleman were the authors. And we used to think maybe left ventricular hypertrophy is also a variant of normal. Now, 40 years down the line, I'm realizing these were people who probably had masked hypertension and not hypertrophic cardiomyopathy, which is very rare. So it just is striking my mind that for a long time we have missed masked hypertension and we haven't managed it well. So the question actually Dr. Ashok Agarwal is asking is, masked hypertension, do you think it is an important cause of HFpEF? Because it will lead to diastolic dysfunction, LVH, and then finally this thing.
See, whatever be the stimulus, if we have an hypertrophied left ventricle, it makes it more prone to go in for a HFpEF, right? Whether it is aortic stenosis, hypertrophic cardiomyopathy, and stage of hypertensive heart disease, whatever. Because the thickened myocardium wants to extract more of energy, and that is not being provided. It goes for an HFpEF. Now, I'm not aware about any study which has looked into HFpEF and tried to do an ambulatory BP to look into the incidence of masked hypertension. But I think it's very interesting. It has not struck me, but it is very interesting. Maybe we can collect a HFpEF where we don't have an answer. Like we don't have an obvious aortic stenosis or a hypertension at hand, and we have an HFpEF, try to see whether they have masked hypertension. Interesting.
Yeah, but at the same time, we will be missing those people where masked hypertension causes eccentric hypertrophy. There probably we may have missed. Dr. Om Kumar, the question for you, sir, and that question is, are new beta blockers better option in young hypertensive, or you will still use ARB?
Indications of beta blocker is like a patient recent MI or patient having angina, young hypertensive with increased sympathetic activity, sympathetic nervous system activity. So in those cases, you have to give beta blockers. The new beta blockers, which are selective, like bisoprolol, metoprolol, these are the better drugs to use in these hypertensive patients because they are having less side effects. And bisoprolol is having many more advantages over other beta blockers. So these are the selective beta blockers which should be used in these hypertensive patients, especially if patient is having heart failure. Yeah.
Yes, Dr. Nair.
Yes, see, this is an area where we also got interested. We found that there's a group of young people who have got an isolated systolic hypertension. We name them isolated systolic hypertension of the young. These are people who typically work in the IT sector. They work at night. They're highly stress prone, and you can actually make them out when they come to your clinic. They will have multiple cell phones. First thing they will come and say, "Sir, I have no problem. My wife told me to see you. Sir, I have no heart disease, sir." By the time they're lying down, one cell phone rings, they switch off, another cell phone rings. They have all project bound. They talk fast. They're very stress prone. Now, this kind of, they have tachycardia, they have every feature of sympathetic overdrive. Now, this kind of isolated systolic hypertensives in the young they feel very well with beta blockers. And selective beta blockers like bisoprolol, nebivolol don't give them an impotence or any kind of erectile dysfunction, and they feel fine. They actually come and tell you that they feel fine. Does it do any better than an ARB? We don't have that data, number one. Second thing is the India heart study, which we were all part of it, showed that the Indians have a faster heart rate. The average heart rate in that population was 83, which is much more than the Westerner, average Westerner. So we had a faster heart rate. So we were asking ourselves the question, do we need to put beta blocker higher up in the Indian algorithm or Indian guidelines for a group of people like us who are highly stress prone and have a faster heart rate? We don't have the answer. But I myself believe that the time is going to come when beta blocker will be again picked up and come forward. See, because obviously, logically, think about that. When a heart fails, we say beta blocker is ideal. Okay, when there is even a slightly failing heart, we say beta blocker is the best. When there is an immediate post-MI, we say beta blocker is good. So how can beta blocker be bad in an usual hypertensive? Of course, we know that we have today agents like ARBs, which are far better in reducing stroke in beta blockers. But that concept that beta blocker increases stroke is simply not tenable. Today, we have much better drugs than beta blockers in reducing stroke compared to anything. That is no doubt about it. And that is why we should restrict our usage of beta blocker toward immediate post-MI within 2 years, or somebody who has got very clear evidence of sympathetic overdrive, or somebody who is pregnant, like, labetalol. Okay. So we have very clear guidelines, but beta blockers are not bad drugs that increase stroke. I think that myth should go away.
No, I think the beta blocker don't increase stroke. The MRC1 and MRC2 trials just showed that they are inferior to diuretics in reducing stroke. And same thing is being said by Escort BPLA. Same thing is being said by Life study. They are inferior. They're not causing stroke. I think we'll take the last two questions. You guys have to have dinner, and me too. And the questions are pouring, but the last two questions. When to suspect renovascular hypertension? And Dr. Shafakar, you take it correct. The way we do it, we cardiologists, whenever somebody comes with flash pulmonedema, we think of renovascular hypertension. When pulses are unequal, especially young females because of aortoarteritis, we think of that. Yeah. When we have a bruit, we think of that. When we give ARB or ACE inhibitors, the creatinine starts rising, we think of that. That is how we dumb-wit cardiologists think, these four things. But anything else we can learn?
So in addition to what you already said, you already answered the question, but in addition to what you already said, extremes of age, I think, should be remembered to suspect renovascular cause. We don't really suspect ischemic renal disease in elderly people, which we should have a high index of suspicion. And secondly, if you do the urine examination in these patients, they will not have proteinuria. I think these two important points which we should remember, because we want to differentiate between a renal parenchymal disease versus a renovascular disease.
So the last question, I'm sorry, the other question would have
Let me just add one comment to that. Yeah. Somebody who's got hypertension very high at a younger age, say less than 20 years, or a new onset of hypertension more than 50 years, you look at renovascular. The second category being the atherosclerotic variety, and the first being probably a renal artery stenosis. So these two subsets, just keep it in mind.
So I have a last question. Yes, Dr. Om Kumar, sir. Yes, sir.
Point to add that in a renal transplant patient, if the control of blood pressure suddenly becomes very difficult, or worsening of graft function, then we should suspect development of renal artery stenosis in the graft.
So our last question, and I'm going to take response of both Dr. Pai and Dr. Om Kumar. First to Dr. Pai. Straight question, is spironolactone safe in CKD hypertensive individuals?
You need to use this drug with caution in patients who are CKD with hypertension. I don't think that it's a written off drug. It is quite extensively used in CKD. It depends on what is the eGFR that you are looking at in that patient. If it is a patient who is having a very low eGFR, then the chances of getting into complications are high.
So, Dr. Om Kumar, the extension of that same question. My point is,
the risk of
please.
Of severe development of severe hyperkalemia in this subset of patient is very high. But if you are able to monitor serum potassium in these patients, so spironolactone or other MRA can be given in these patients. Recently, you have already mentioned about finerenone, which have been used without the fear of developing hyperkalemia in these patients. So yes, in difficult refractory hypertensive patient, spironolactone can be used even in CKD patients.
So my last point to three of you nephrologists, we see good number of CKD patients with hypokalemia either per se or with loop diuretics, and you can call it potassium losing nephropathy with CKD, potassium losing nephropathy. And in my own practice, I see about 5% of such individuals. From three of you, I want to learn what is the prevalence of persistent hypokalemia in CKD. Are these good candidates for spironolactone? And we are going to end after that.
Okay, I'll take that first.
Yeah.
So if you look at the causes of CKD, then you have a category called as tubulointerstitial nephropathy. So whenever you have a chronic tubulointerstitial nephropathy, these people are not oliguric patients. They have good amount of urine output, but they have CKD. In that category of patients, you are more likely to have hypokalemia. And if you look at the incidence of chronic tubulointerstitial nephropathy, it is to the extent of 10 to 12% as far as the CKD incidence is concerned. And there are various causes of CTIN. One of them is immunologic, the second one is toxic. So in that subcategory of patients, if you have hypokalemia, then if you have resistant hypertension, then probably you are okay as far as spironolactone is concerned. But remember that if it's a tubulointerstitial nephropathy, the incidence of refractory hypertension in that subcategory is very, very less as compared to a glomerular disease. So therefore, again, when you require spironolactone in a patient with CKD and hypokalemia, the number of patients would be definitely less because they are very, very subcategorized as far as the incidence is concerned.
Yes, but there is a category which who have heart failure with CKD with hypokalemia. That number probably 10 to 15%.
Okay.
Dr. Pai, your comment, and Dr. Omkar, first Dr. Pai, your comment on hypokalemia, hypertension and CKD.
It is quite common. I feel it is probably contributed by the concomitant drugs which are used for treatment of heart failure. And more often than not, we tend to add an ARB or any other MRA to negate the effect of hypokalemia of a loop diuretic. The incidence in our clinical practice is nothing less than 25%.
Good. Dr. Om Kumar, sir?
Yes, I agree with the answer given by other panelists and experts that it is not uncommon, 10 to 15%, and most of the times the hypokalemia is iatrogenic, produced by the drugs, overzealous restriction in the potassium containing food, and then on top of that taking losing diuretics. So yes, if patient is having heart failure, in those cases we should use spironolactone in these patients.
Thank you, panelists. Thank you, my speakers. And I think it's 1 hour and 55 minutes. And even our sponsors are thinking, when am I going to wrap it up? And so over to Dr. Mithilesh, over to Amit.
You need to unmute, sir.
You have to unmute yourself, Amit.
So thank you very much, Dr. J.C. Mohan. First of all, festive greetings to all of you, all the delegates from here at INTAS. And, this is the 5th program of Practice Pulse in Hypertension, and consecutively, we have more than 1,000 delegates attending this program. And in the first program, which we did, sir, Dr. Soumitra Ray was the speaker, and he said hypertension is boring. But it does not seem to me, listening to all of you and the kind of interest this has actually generated with all the delegates and the kind of interaction which has happened over last 1 hour and 55 minutes. It's mind-boggling, and there are so many questions people have, and I'm sure your chat box is full of questions which you are still not answering now. So I must thank you for generating so much of interest in this program. I must thank our speakers for the day, Dr. Tiny Nair from Trivandrum and Dr. Devdutt Chafekar from Nasik. You have done your lectures wonderfully well, and I must thank the panelists for the day, Dr. Narasimha Pai and Dr. Om Kumar, for being making the program very interactive. So, this is our commitment to continue these programs. We do these programs on second Saturday of every month. But since this second Saturday was Diwali, but we had the commitment to continue the program, so we preponed the program today. And next time we meet on the second Saturday of December with some more interesting topics. And of course, Dr. J.C. Mohan is going to be with us for the program. Sir, we were talking about, I want to ask one question to all the panelists. Since we were talking about the young hypertensives and a lot of sympathetic overactivity, and cilnidipine is one drug which has shown to reduce heart rate in some of the patients. And beta blockers, you say, is not the choice of drugs in many of the patients. So would you consider cilnidipine for that particular indication wherein it reduces? There is a trial called there is a study called Achieve One study wherein they have shown the reduction of by around 5 to 6 beats per minute with cilnidipine. So I want your comment or your answer on this, sir.
Yes, so the Dr. Tiny Nair actually took us through that muscle sympathetic nerve activity business. All antihypertensive drugs, ARBs, ACE inhibitors, beta blockers, they decrease MSNA in hypertension, untreated hypertensive. Then you give drugs, but they never bring it to the normotensive level. That's what he was showing. His slide, remember? But he showed white coat hypertension, mass hypertension. We have data from amlodipine which says that the MSNA activity goes up. We have some data with cilnidipine that MSNA activity comes down, but it is of the same magnitude as ARB and ACE inhibitors. So the point actually is, does he have any great advantage? I don't know. As far as decreasing MSNA is concerned, certainly cilnidipine scores over amlodipine. That would be my short comment without getting into the argument where is the outcome data with cilnidipine versus amlodipine.
Right. Thank you for that, sir. And this brings us to the end of the program. So thank you very much. And two more things I would like to announce here. One is, INTAS is doing a lot of research work in this COVID-19, and very recently we have come out with a patented drug, thymoquinone, which is an adjunct to the standard therapy for COVID-19, and it boosts immunity. So this drug is now available for the patients. And secondly, very exciting time for us, we have introduced Dapavel, which is dapagliflozin in India at a very economical price of 12 rupees for 5 milligram. 10 rupees for 5 milligram and 12 rupees for 10 milligram. So, from 60 rupees to 12 rupees in India, Dapavel is available now across the country. So these are the two exciting announcements we wanted to make. So thank you very much once again. Thank you very much to all of you for being such a wonderful, faculty today and making this program successful. Thank you very much and good night.
Thank you. Thank you, Amit.
Thank you.
Thank you.
Thank you. Thank you.
Dr.
Bye. Good night. Good night.